My name is Chris Marino. I am one of the therapy managers for Town Center Orthopedics. I'm a board certified orthopedic specialist, and I'm going to be talking a little bit today about taking care of a total knee replacement. One of the first things we see that we have a big problem with is people over medicating. People think that therapy is going to be hurtful and painful, so they will typically take medication right before they show up here. I typically tell patients not to do that. I tell them to focus on taking it as they feel like they need to, and not to come in thinking that therapy is going to hurt more. The whole idea of therapy is to make you feel better, not worse. So don't come in with the idea of thinking that you need to take a lot of medication to cover your pain, because what actually winds up happening is patients become more guarded, more nervous, and then they're unable to progress to day one, day two, day three as they'd like to. Remember, the goal of therapy is to make you feel better, not to get it worse every time you come. So another topic people have questions about a lot is how much to ice or when they should ice. I've had patients tell me that they ice 24 hours a day. They'll keep the machine on that the doctor provides them and let the water just keep running and keep the knee as cold as they can. We don't recommend this. In reality, you only want to ice for about 20, 30 minutes at a time and give yourself a break for about at least an hour, if not more. The whole idea of icing is to decrease inflammation, but your body will actually increase blood flow to an area if you have the ice on for too long to stave off frostbite. We want to keep the swelling down, but it's not necessary to keep the ice in there 24/7. Otherwise, you could cause more inflammation to your knee as well. So, another issue our patients often have is asking us, when can I stop using the walker? When can I stop using the cane? How long do I have to use it for? What I generally tell patients is it's about making sure you have proper mechanics walking before giving up the device. A lot of people feel like they're doing well, so they stop using the device, but what they wind up doing is favoring the leg and cheating and using spots in their leg that they shouldn't be using and keeping their knee bent, keeping their self flexed forward. And what winds up happening is that you keep putting more force through the knee or the hip, which then gets it irritated and starts to swell again, and then you have more pain. So it becomes a situation where people have 2 steps forward, 1 step back, and start to get frustrated. I always recommend my patients take it nice and slow, focus on gait mechanics, focus on being able to walk properly, getting the full knee extension, full hip extension, and being able to stand erect prior to losing assistive devices. Otherwise, we want developing contractures from favoring the knee and favoring the hip. Another topic that comes up frequently is people ask when they can go back to driving or when they can go back to work. These things take time, specifically depending on which limb is affected. My general rule of thumb, if it is your right leg and it is the one that you'd be driving with on the gas or on the brake, if you had to hesitate on slamming on the brake, then you shouldn't be driving. Most of the time, it's the stiffness in the knee that you have the inability to be able to bring your leg back and forth, or pain in the front of the hip from a hip replacement that doesn't allow you to be able to move your leg back and forth quickly. That can cause detriment with driving and is the biggest safety risk. Now, I bring this up because people often ask, when can I go back to work? A lot of people have to drive to go to work. Sometimes driving doesn't bother them, but the long walks, people underestimate how far they'll have to walk and how much they can take, as well as sitting for extended period of times at a desk, how much the knee swells, how much they can get up and move around, and how long they have to get back from their desks. So the reason that driving is important is that people often want to go back to going to work. Now, people often underestimate how far they have to drive for and how long they have to sit at the desk for. They will often say, I can elevate my leg, I can get up a couple of times a day. What we find out is people get rushed and they feel like they can't do their stuff, and then they wind up having more swelling and pain. General rule of thumb is that we would really recommend probably about 4 to 6 weeks before they think about going back to work full time. The reason I recommend 4 to 6 weeks is because it usually takes about 2 to 3 weeks before the initial swelling dissipates, and before 6 weeks before people feel comfortable walking around without a whole lot of pain. The pain dissipates over time, but if you have to sit at a desk for an extended period of time, the knee will feel stiff, it feels achy, and then it's harder to start moving around. And once people commit to going back to the office, it's kind of hard to take a step back and then take a break if they need to. And what people wind up doing is developing contractures, not being able to bend their knee as much, not be able to straighten it as much, It takes a little bit longer for people to be able to start walking more normally after keeping themselves in a flex position for a long period of time, such as sitting in a car for a long period of time or sitting at a desk for a long time. So finally, the last thing that we usually see people have a problem with is they don't take a less is more approach to doing therapy. They generally feel like they're weaker, they got stiff, they're worried about atrophy, they're worried about not be using their leg. What people need to remember is that you don't atrophy the day you have surgery. It takes 4 to 5 weeks for actual atrophy to set in. You will start to see decreased muscle tone because the muscles aren't engaging as much. But the muscles aren't cut during surgery, they don't remove anything. You have the same muscles there prior to surgery as you do afterwards. What happens is that the swelling limits the knee from being able to move or the hip being able to move. So we have to take time to focus on increasing fluid mobility. The main idea behind fluid mobility is muscle contraction. People often think that their muscle is weakened right after surgery. They don't. The doctors don't cut any of the muscles. They don't remove any of the muscles. Okay. What happens that people feel weaker is because there's swelling. All you need is 10 to 15% increased swelling in the muscle to disengage the muscle. What that means is that you have a less ability to contract the muscle after surgery because of the swelling. So what we want to do is focus on reducing the swelling. Okay. Your heart pumps fluid everywhere. The only thing that gets it back up is muscle contraction. So by doing some light active range of motion movements, pumping your ankles, sliding your heel, squeezing your quads, all starts to push the fluid out of your leg. Now it will continue to happen because your body's still healing. The initial swelling takes 2 to 3 weeks to dissipate. So what we always recommend is to slowly just start actively moving the knee and actively moving the leg and feel the muscles squeezing as much as you can. But don't worry about trying to crank out as many exercises as you can. Don't worry about trying to do a whole bunch of strengthening stuff. It's not that your muscles atrophied and you got weaker. It's the fact that you had surgery and still need to recuperate. The more time we take focusing on reducing the swelling, the less time we need to spend on trying to retrain how to actually use the leg and focus on strengthening later on.